Department Al-Maadi Military Hospital. He is one of the experts in pediatric endocrinology and diabetes, and so on. Professor Sameh, please.
Thank you very much, Dr. Nagy. Thank you very much. Bismillah ar-Rahman ar-Rahim. My talk today is about complete congenital heart block. The agenda of my talk will be, I will discuss the types of AV heart block, first degree, second degree, third degree, and complete congenital heart block incidence, etiology, prognosis, and indication of cardiac pacemaker. First degree heart block is just as simple as just prolongation of PR interval. No intervention is done, normal phenomena occurs in about 6% of normal neonate. It needs no intervention, so whatever. Diseases associated with first degree heart block varies from hypothermia, rheumatic fever, increased parasympathetic tone, electrolyte, hypocalcemia, hypokalemia, hyperkalemia, hypercalcemia, hypomagnesemia, hypoglycemia, etc. Congenital heart disease, Duchenne muscle dystrophy, drugs as digoxin and calcium channel blocker as well. Newborn heart rate is normally from 120 to 160 beats per minute. If it is less than 100, it is defined as bradycardia, and if it is greater than 180, it is diagnosed as or defined as tachycardia. The BR interval is measured from the onset of the B wave to the Q or R wave. If there is no Q wave is present, the BR interval is measured in lead number 2, and it increases with age and decreases with heart rate. The normal neonatal PR interval ranges from minimum of 70 milliseconds to the maximum of 140 milliseconds, and with the mean of 100. On the top, ECG is normal, and on the bottom, first degree heart block 1-to-1 manner. Second degree heart block is a failure of at least one non-premature atrial impulses to conduct to the ventricles, two types, MOBIS 1 and MOBIS 2. I wouldn't talk much about first type 1 of secondary heart block, but this is the ECG, or even the second, MOBIS 2. I will talk about third degree heart block. It is complete atrioventricular dissociation. BR interval is variable. RR interval is constant. Diagnosis is based on B wave that should conduct, don't do so, as in TGA. The incidence is 1 in 15,000. Etiology, about 90%, up to 90% connective tissue disease in the mother, as lupus or Sjogren syndrome has been blamed for congenital third degree AV heart block. This is due to maternal transfer of IgG antibody, anti-Rho and anti-LA. Sometimes manifest with carditis. There's sometimes also the structural heart disease, or structural heart defect, and congenital absence of the AV node. Clinical manifestations of third degree heart block, the congenital one, fetal bradycardia and hydrops, neonatal bradycardia, up to heart failure and acidosis as well. Pacemaker indication in type 2, second degree, or third degree AV complete heart block with symptomatic bradycardia or poor cardiac function. Also, postoperative type 2, second or third degree AV heart block that is not expected to resolve or be resistant for more than 7 days following cardiac surgery. Congenital complete heart block with wide QRS escape rhythm and the complex ventricular ectopy or ventricular dysfunction. Congenital third degree AV block in infant with ventricular rate less than 55 beats per minute or with congenital heart disease and the ventricular rate less than 70 beats per minute. On the top, the normal ECG. On the second is the first degree heart block with prolongation BR interval. And third one is second degree AV heart block 2-1. And the third one, there's a complete dissociation between atrial contraction and the ventricular contraction. And their dissociation, each one is doing what on his own. There is no harmony between the atrial and ventricles. And this is how the third degree heart block looks like in the ECG. If it is the block is above the AV node, the above, or the block is below the AV node as below. I would like to present a case. One of neonates who was admitted to my units, and this was about 10 years ago, in July 2013. And she was admitted in the same day, of course. The personal history, she was a female, 30 weeks age, gestation, first offspring of non-consanguineous parents. And she presented with slow heart rate at birth. At birth, heart rate was 40. And as all we know that heart rate is normal from 120 to 160 and very less than 100 and taking more than 180, as we mentioned before. Atropine was given and the heart rate improved to 50. It's still very low. The baby was admitted to our NICU. Perinatally, for the ultrasound was done, showing differential in the atrial and ventricular beats. Atrial, I remember that it was 150 and the ventricular one was 60 or 70. So there's a dissociation. Natally, cesarean section with birth with 3.8 kilograms. Postnatal, admitted to our NICU. Family history, non-consanguineous parents, no history of similar condition as they mentioned. Mother is 25, no medical problems apparently. Father is 29 years, no medical problems. The grandmother, when we got to the history and details of the family medical history, the grandmother is a known case of SLE. And the aunt was SLE as well. On examination, baby was active, alert, although heart rate was 50, respiratory rate was 30, weight 3.8 kilograms. Its circumference was normal, 37 on the 90 percentile. No pallor, no jaundice, no cyanosis, and no abnormal or dysmorphic features. When examining the abdomen, it was lax, no organomegaly, and chest was bilateral equivalently normal, heart normal, apart from the bradycardia. But no shock, no cyanosis, no acidosis. Back, genitalia, limbs, all were normal and no abnormality detected. When doing the lab investigation, CPC, hemoglobin, platelet, TLC, all were normal, and the chemistry starting from urea create, random glucose, sodium, potassium, ALT, albumin, total bilirubin, calcium, and ionized calcium actually all were normal. We did septic screen, and CRP was 6, TLC was 10.5 thousand. Blood culture, no gross. EBG, normal pH, CO2 was normal, and bicarb was 16.8. We did immunology screening for the baby, and the anti-SSCB was 270, and the normal values was up to 20. And anti-SSA was 265, and the normal values was maximum 20. This done for the baby, and for the mother, it was 260 and 265. And anticardiolipine IgG was normal, and the anticardiolipine IgM was mildly elevated. And the anti-DNA was looks within normal values. As you see here, it was 310, and normal values was from 200 to 800. And this is the ECG. And this is the actual ECG. I insisted to put it as it was. ECG was complete heart block, atrial ventricular dissociation, and the heart rate was 50 beats per minute. Management. On day 2, following birth, temporary pacemaker was done. In the right, and inserted in the right ventricle, and confirmed by fluoroscopy and bedside echocardiography. Heart rate improved markedly from less than 50, from about 40 to 110 normal values, and blood pressure improved as well. 85 systolic and diastolic was 50. Capillary fill time less than 3 seconds. SpO2 98. Urine output 1.6 mil per kg per hour. Actually, we weren't sure of the diagnosis. We put him on antibiotics and IVIG. And we started low molecular weight heparin at 1.5 unit per kg every 12 hours, increased to 1.7 unit per kg every 12 hours as well. And this is a temporary pacemaker. And this is the baby when he was in the incubate in our NICU. This was 2013, 10 years ago. Pacemaker was functioning, heart rate improved, as I mentioned before, to 110. And this is the ECG. Echo showed temporary pacemaker in the right ventricle, ACD for MM, and tricuspid functioning tricuspid agarage was iatrogenic, normal pulmonary pressure. On day 6, permanent pacemaker by our pediatric cardiac surgeon. It was a bicardial. Heart rate was 120, blood pressure 70, systolic and diastolic 50, respiratory rate 40, SpO2 97. Blood culture was Klebsiella. And it was sensitive to cefepime, and cefepime was added to combat this infection. I'm sorry. And this is when we were in the operating room helping or assisting the surgeon, the pediatric surgeon, who did the permanent pacemaker. Temporary pacemaker was removed, the molecular weight heparin was stopped. All lab investigations were normal, including chemistry and CBC. And CRP was negative, blood culture normal. And this is the ECG with the heart rate 120 beats per minute, and the pacemaker was functioning. At the age of 7 months, weight was 8, Its circumference was 44, and height was 73 centimeters. It was doing fine developmentally, either motor or social or the patient was on regular follow-up for every 6 months to check for the pacemaker functioning and the battery. At the age of the 3 years, the pacemaker was changed because the battery was out of charge. When we referred the mother for our rheumatologist consultant, the mother had Sjogren syndrome. She was maintained on Solopred, Kilixan, and Bileconine. When she got pregnant, again, she was in a regular follow-up for the fetus by serial fetal echo, and all were normal up to a certain point. The mother received IVIG during pregnancy. At 35 weeks of gestation, the child has prolongation of PR interval, but in a physiological range. So decision was made to deliver this fetus by cesarean section. Second baby was a female, born by cesarean section, and it was completely healthy, normal neonate. This is a story of our complete congenital heart block done in my hospital. Thanks to the staff, pediatric cardiology, pediatric cardiac surgery, CHO, senior registrar, and nursing staff. And this is the department and the head of the department. And this is staff, and this is our previous chairpersons of pediatric department at Maadi Hospital. Thank you very much.
Thank you very much, Professor